Greetings, enthusiasts of the medical world, and a warm welcome back to ERMP and Beyond, your premier destination for delving into the heartbeat of clinical medicine. As always, we're set to navigate the practical aspects of medical science, dissecting intricate cases that both challenge our intellect and expand our knowledge. In this platform, we confront the real-world scenarios of healthcare. Together, we'll deconstruct complex diagnoses and sharpen our clinical acumen. Anticipate engaging in evidence-based updated protocols, enriched by the priceless perspectives that stem from actual medical practice. So, without any delay, let's dive into the depths of today's medical enigma. A 20-year-old female presented to emergency within 4 hours after ingestion of 15 grams of paracetamol for suicidal attempt. What is the recommended therapy? A. Flumazenil. B. N-acetylcysteine. C. Hemodialysis. D. Thiamine. Let's first revise the revised Rumax-Matthew nomogram, shown on the right side of the screen. It is a critical tool for managing acute acetaminophen ingestion. Picture this: someone has just ingested a potentially toxic dose of acetaminophen. What's our first step? We need to measure the serum acetaminophen concentration, ideally between 4 to 24 hours post-ingestion. Why? Because we want to catch the peak concentration to accurately assess the risk of toxicity. Now, imagine you have the serum levels in hand. You'll plot these on the nomogram, aligning them with the time since the acetaminophen was taken. This is where it gets crucial. The plot will reveal the potential for toxicity and whether treatment is necessary. If the data point falls on or above the treatment line, it's a clear signal. Acetylcysteine therapy is warranted to mitigate the risk of hepatotoxicity. But what if the point is not just on the line but above the high-risk threshold? In such cases, many experts recommend a higher dose of acetylcysteine. It's a proactive measure to counter the increased risk. However, there are limitations to this tool. It's not a one-size-fits-all solution. If the patient's history of ingestion is unclear, or if the ingestion happened more than 24 hours before they came to us, the nomogram isn't applicable. The same goes for cases of repeated, supratherapeutic oral doses or an overdose administered intravenously. In these scenarios, we need to look beyond the nomogram and consider other factors and treatment protocols. Let's understand first the risk for liver injury. When faced with an acute ingestion of acetaminophen, it's crucial to measure serum concentrations within 24 hours of the first dose. This data is then plotted on the revised Rumax-Matthew nomogram, a tool that helps us predict the likelihood of liver injury. However, as discussed in the previous slide, it's important to note that this nomogram isn't applicable in cases where the patient's history is unreliable, or if there's been a repeated supratherapeutic ingestion, which refers to multiple doses over a period extending beyond 24 hours. Moving on to gastrointestinal decontamination. This is a proactive measure taken when a patient presents within 4 hours of ingesting a potentially toxic dose of acetaminophen. If the ingested amount is equal to or exceeds 150 mg per kilogram or a total of 7.5 grams, administering activated charcoal is recommended. The dosage of activated charcoal is calculated at 1 gram per kilogram of the patient's weight, with a maximum cap of 50 grams. It's administered orally, but there are certain situations where it's contraindicated. For instance, if the patient has a gastrointestinal obstruction or if their mental status is altered to the extent that their airway is unprotected, activated charcoal should not be given. Moreover, it's imperative to understand that tracheal intubation should not be performed solely to administer activated charcoal. Let's continue our discussion on the actual management of acetaminophen overdose. Our primary concern is the risk of hepatotoxicity. If the patient's acetaminophen concentration is above the treatment line on the revised Rumax-Matthew nomogram, or if there's liver injury with exposure to acetaminophen, we turn to acetylcysteine as our antidote of choice. The efficacy of acetylcysteine is highest when administered within 8 hours of ingestion. However, it's important to note that it can still significantly reduce the need for a liver transplant and decrease mortality rates, even when liver injury is present without detectable acetaminophen in the serum. Now, who exactly should receive acetylcysteine? First, any patient who has had an acute ingestion and whose serum acetaminophen concentration, measured 4 hours or more after ingestion, is above the treatment line on the nomogram. Secondly, if there's a suspected single ingestion of more than 150 mg per kilogram, which equates to a total dose of 7.5 grams regardless of the patient's weight, and the serum acetaminophen concentration won't be available for more than 8 hours post-ingestion. Thirdly, if there's a reliable history of repeated supratherapeutic ingestion with a serum acetaminophen concentration of 20 micrograms per milliliter or higher, or if liver aminotransferases are elevated beyond the patient's baseline value. Fourthly, in cases where the history is unreliable and the acetaminophen concentration exceeds 10 micrograms per milliliter, or again, if aminotransferases are elevated beyond the patient's baseline. And lastly, if there's any history of acetaminophen ingestion accompanied by evidence of liver injury. Now, there are various dosing protocols for acetylcysteine, and it can be administered either intravenously or orally. Intravenous administration is the preferred method, especially in cases where the patient is experiencing vomiting, has a non-functioning bowel, is pregnant, refuses oral administration, or presents with liver injury. The most commonly implemented acetylcysteine dosing protocols include the 21-hour intravenous protocol, the 20-hour 2-bag intravenous protocol, and the oral protocol. Regardless of the chosen protocol, the goal is to administer at least 300 mg per kilogram of acetylcysteine during the initial 20 to 24 hours of treatment. Coming to the duration of the therapy, we don't just watch the clock, we look at clinical endpoints to decide when to stop the treatment. We discontinue acetylcysteine therapy after a minimum of 300 mg per kilogram has been given over 20 to 24 hours. And only if all the following criteria are met. The serum acetaminophen concentration drops below 10 micrograms per milliliter, the international normalized ratio is less than 2. The levels of liver enzymes are normal or returning to baseline, and the patient is clinically well, meaning they're not experiencing nausea, vomiting, or abdominal pain. It's important to note that between 10 and 20% of patients who receive intravenous acetylcysteine experience a non-allergic anaphylactic reaction. If a patient develops symptoms like flushing, we pause the acetylcysteine infusion for 15 to 30 minutes before resuming at the previous rate, unless more severe symptoms arise. For more severe reactions, we manage the situation with intramuscular epinephrine, diphenhydramine, and a glucocorticoid. Moving on to Fulman and hepatic failure. This condition is marked by the onset of impaired synthetic function or encephalopathy, distinguishing it from mere liver injury. In such cases, acetylcysteine has been shown to reduce mortality and the necessity for liver transplantation. The modified King's College criteria are instrumental in determining the prognosis without the need for liver transplantation. In situations involving high-risk acetaminophen ingestion, particularly when a patient presents with a serum acetaminophen concentration equal to or exceeding 900 micrograms per milliliter and displays altered mental status or metabolic acidosis, hemodialysis is recommended alongside acetylcysteine treatment. Hemodialysis not only clears acetaminophen and its toxic metabolites from the serum but also corrects metabolic acidosis. Cases of exploratory exposures in young children typically involve small quantities of acetaminophen and present in an otherwise asymptomatic child. Fortunately, these incidents rarely lead to liver injury and are managed similarly to acute ingestions in adults. In the case of a 20-year-old female who has ingested 15 grams of paracetamol, the recommended therapy is N-acetylcysteine. N-acetylcysteine acts as a precursor for glutathione, helping to replenish intracellular stores. This is crucial because glutathione is needed to neutralize NPK, the toxic metabolite of paracetamol, which is produced in an overdose situation. Early administration of N-acetylcysteine, ideally within 8 hours of ingestion, can significantly improve the outcome by preventing liver damage. Option A, flumazenil, is an antagonist of the benzodiazepine receptor and is used to treat benzodiazepine overdose, not paracetamol overdose. Option C, hemodialysis, may be considered in severe cases of paracetamol overdose when there is significant renal impairment or when the levels of paracetamol are extremely high and not expected to be effectively reduced by N-acetylcysteine alone. However, it is not the first-line treatment. Option D, thiamine, is used to prevent Wernicke's encephalopathy, particularly in patients with alcohol use disorder, but it does not play a role in the treatment of paracetamol overdose. The management of paracetamol overdose includes initial assessment, stabilization of the patient, and administration of the antidote, N-acetylcysteine. The decision to administer N-acetylcysteine is typically based on the time since ingestion and the amount of paracetamol ingested, using the Rumax-Matthew nomogram as a guide. If the patient presents within 4 hours of ingestion, activated charcoal can also be administered to reduce absorption. It's important to monitor liver function tests and renal function, as well as coagulation profiles, to assess the extent of the overdose's impact. In summary, N-acetylcysteine is the antidote of choice for paracetamol overdose, with its effectiveness being highest when administered early, and other options such as hemodialysis are reserved for more severe cases. For a detailed discussion on the clinical features and stages of paracetamol overdose, please refer to our previous discussion on case number 18. The insights from that session will provide a comprehensive understanding of the treatment protocols and the rationale behind them. The link to the video is provided below in the description. Moreover, I will post you an important slide on adult and pediatric acetaminophen poisoning in my Telegram channel. As we conclude this session, I trust that your active participation is what breathes life into these discussions, making them truly impactful. Should you find value in this video, kindly show your support by liking it. Your opinions matter greatly, so do not hesitate to leave your comments below. Sharing this video would help disseminate the knowledge shared here. Subscribing to this channel ensures you stay informed about new content, keeping you at the forefront of our ongoing conversations. I am looking forward to furthering our explorations together and eagerly anticipate our next meeting. Until then, my gratitude for your time, your eagerness to engage, and your readiness to learn and contribute. Until our next exchange.